very much for the kind invitation from the organising committee. Just wait for the slides to come up. So I'm going to talk about, I'm a surgeon that does a lot of radiology, particularly MRI. So I'm going to talk about the important imaging factors for the rectal cancer surgeon. So if we look at the last 100 years or so, and we divide up how we have managed to investigate rectal cancer, I break it down into three eras: that of Miles, then Bill Hild and the TME, and then the era of oncology, and particularly neoadjuvant therapy. And this really defined what we see now as our surgical oncology and surgical anatomy. We now, as surgeons, work in a multidisciplinary team, and that means that we can optimize our patient outcomes. But of course, we still need to use the MDT for ourselves to optimize our own surgical outcomes. And these are some of the features that I think that are important for the rectal cancer surgeon. We need to know about the circumferential resection margin. We want to know whether our patient has nodal disease. The height of the tumor can often determine our approach, and whether our patient needs chemoradiotherapy and the consequences that we've heard so eloquently earlier in the morning. We must discuss these factors not only within the forum of the MDT, but perhaps separately with our radiologist in planning the surgery. Fortunately, all of these features can be seen using a high-resolution protocol on T2 weighted images. Now, if I went around the room and asked everybody what is the most important single defining paper in the history of rectal cancer, we'd probably get 50 different answers in the room. But about a decade ago, this gentleman stood up at the Royal Society of Medicine and said this was the single most important paper in the history of rectal cancer. And this, of course, is the original report from the British Medical Journal for the Mercury study. We've seen since the report of this that MRI now plays a huge central pillar in the MDT. Not only is it involved in the decision-making of neoadjuvant treatment, but it helps us plan our surgical treatment and then can often help the pathologist and guide decisions with adjuvant treatment as well. We can see CRM, T-stage, nodes, height, restaging, and of course these are some of the factors that I mentioned earlier that to us as the rectal cancer surgeon is particularly important. So taking individually these particular factors, we know from this seminal paper by Arnie Wiebe that a threatened CRM leads to poor prognosis when it comes to local recurrence. The debate of whether this is 1 millimeter, 5 millimeter, 1 centimeter may still go on, but of course we know when we see tumor nearby the resection margin, that is a bad prognosis in whether we're talking about an advanced cancer or whether we're talking about a polyp. So this is a T2 weighted image. We can very clearly see now on these images, and most of my colleagues too that will study these images beforehand can at least identify the mesorectal fascia. Now it's important at this stage to differentiate what we call the circumferential resection margin from the mesorectal fascia. The mesorectal fascia is an anatomical boundary that surrounds the mesorectum. The circumferential resection margin is a clinical term that we use as surgeons and clinicians to define the tumor and the pathology. So this red line, mesorectal fascia or circumferential resection margin, can be very, very clearly seen on these images, and you can see where the tumor relationship is from it. And the gray bit in the middle is the mesorectum, and we'll see how that develops in some future images. In this particular slide, you can see as the tumor now extends out towards that line. I'm not sure whether that works. So here, we can see the circumferential resection margin coming round, and we can see the tumor going towards the circumferential resection margin and extending into the circumferential resection margin. So if we carried out a traditional TME type operation, we're going to get a positive resection margin here. This one is a little bit more subtle, and as you begin to see the circumferential resection margin here, you can see that the tumor is encroaching it, but perhaps is not breaching it. So we've got a situation where it can be more obvious, where you've extended into the circumferential resection margin, and then you've got a situation where it's beginning to broach the circumferential resection margin. And if that's the case, what we want to know is that are the images that we're seeing on MRI, do they correlate with pathology? And if they do correlate with pathology, how accurate are they? There has been debate, and this margin in MRI we have seen come down 5 millimeters, 2 millimeters by Beats-Tan, and then 1 millimeter by Gina's group. This paper, looking at the mercury data set, suggests that if you are within 1 millimeter, which is this line here, your time to recurrence is bad. But anything above that, whichever cutoff you choose, 2 millimeters, 5 millimeters, is all pretty much the same. So we now in the UK accept that 1 millimeter on MRI scan is what we use to predict the circumferential resection margin. So a tumor within 1 millimeter of the circumferential resection margin is considered to be a tumor that is at risk of an R1 resection. Now, just moving on slightly from the resection margin, just to explain the T stage, and in particular the T3 substage. When you look at the T3 tumors, you can have, which is a tumor that's breached the muscularis, you can see that this is a T3 tumor, but also this is a T3 tumor. So you're going to get heterogeneity between those tumors. They're not all going to behave in the same manner. And this tumor here, which is T3, the smaller one, is nowhere near the resection margin, as minimally penetrated into the mesorectum, as opposed to the larger one, which has penetrated deeply into the mesorectum. To show you on the images, going back to our T2 weighted image, we have our line around the outside of our mesorectum. We have the tumor here, and this gray bit along here is the mesorectum. A T3 tumor that breaches the muscularis will be able to move anywhere along this white line and then be substaged. And we know from work from Merkel, Willett, that the T3 and Hermannick, that the T3 substage is prognostic. And we can see that on MRI as well. This is our earlier graph that we saw when it came to with it being within a millimeter of the circumferential resection margin, but the slides at the bottom show here where we've got minimal breach, if any, into the mesorectum, so that would be a T3A. The second one along has 5 millimeters or less than 5 millimeters, that would be a T3B. And then we move on to the poor prognostic ones, which are more than 5 millimeters, so 5 to 15 being T3C, and more than 15 being T3D. And we have seen now, looking at the mercury data set in greater analysis, that T3A and T3B tumors behave similarly to T2 tumors. So when your radiologist comes to you and says, actually, I'm finding it difficult to differentiate between a T2 tumor and a T3A tumor, actually, it clinically and prognostically makes no difference, provided there are no other adverse prognostic features. It's the T3C and the T3D that we look at. And the protocol that we use again in the UK is that those tumors which are T3C and T3D are the ones that would go on to have long-course chemoradiotherapy. The next contentious subject, that of EMVI. Now, EMVI can be seen very clearly on T2 weighted images, but the importance is to understand the anatomy of the vasculature in the rectum. And it's difficult always to see on a singular shot, and you often have to scroll up and down the images to see whether this is a discontinuous deposit, a nodal deposit, or a vein. And there are characteristic features that we can see on the T2 weighted images that tells us that this perhaps is EMVI, which is defined as cancer cells in the veins outside the muscularis. This paper from Smith from about a decade ago also, looking at primary tumors predominantly, showed that if you've got histological EMVI status, you do badly. 73% versus 28% when it comes to disease recurrence. The same set of patients had an MRI scan as part of the Mercury study, and when we look at that, the graphs are almost identical. We can see that MRI, EMVI, and pathology, EMVI, very much mirror each other. In this study of 200 patients that we did of those that had neoadjuvant chemoradiotherapy, because that is often a suggestion that once you've had neoadjuvant chemoradiotherapy, the scans become more difficult to interpret, we again did something very similar. And those patients that had YP, so that is after having neoadjuvant chemotherapy, pathological EMVI status, and after having chemoradiotherapy, MR, so this is a restaged MR scan, again, the graphs are very, very similar. And interestingly, another part of this particular study was that of these 198 patients, MRI or YMR EMVI rates were higher than YP EMVI rates. And the graphs were identical, which means that perhaps if we rely on pathology alone, particularly after chemoradiotherapy, where much of the architecture is often destroyed, we may miss patients that have EMVI positive disease, and perhaps going back to the MRI scans and the pathologist and the radiologist working together, we could pick up more accurately some of these prognostic features which determine adjuvant treatment. This is another study of EMVI after chemoradiotherapy, and in this what we see, and looking at the lines individually, at the top you've got patients that have had chemoradiotherapy, and this is a matched group, and those patients at with the graph at the top are stage 2, so node negative, and EMVI negative patients, and they surprisingly do the best. The graph at the bottom is this blue one here, are stage 3 patients, node positive, with EMVI positive disease. These patients, unsurprisingly, do the worst. In the middle, you have this interesting scenario where the red line here is stage 2 patients that are EMVI positive, that in many centers around the world would not get adjuvant treatment if there were no other prognostic factors. And the one above, which is ever so slightly better, is a stage 3 patient with EMVI negative. And that patient would normally go on to have adjuvant chemotherapy. So we have these stage 2 patients, again a heterogeneous group that behave very differently, and some of these prognostic features, such as EMVI, may well determine whether or not they receive adjuvant therapy. And it may be that in these patients, particularly as often the metastases goes to the liver within 2 or 3 years, that we should be looking at EMVI in a bit more detail. So then nodes. Firstly, MRI, albeit the gold standard, there is no accurate way of differentiating nodes on imaging. MRI is the best we have. However, how you decide to determine whether you've got a malignant mesorectal node or not remains contentious, but it shouldn't be. This is one of those few situations in life where size actually doesn't matter. In this particular case, you look at the tumor heterogeneity of the signal and you look at the contour. Often this correlates with size, but it is actually the radiological features of the border of the node and what the signal looks like more important than the size itself. But if these are mesorectal nodes, who cares? Because they're coming out if you perform decent surgery. You don't need to give neoadjuvant radiotherapy or chemoradiotherapy on the basis of nodes alone. And we've already heard the consequences of giving those patients unnecessary neoadjuvant treatment, and we have to be more selective about it. So, you can explain this very simply with this picture here. If you do poor surgery and you leave these nodes behind, it is unsurprising that you're going to get a local recurrence because you left the nodes behind. What we have been taught in traditional dogma in the rectal cancer trials in the last 30 years is that nodes require radiotherapy. They don't. They require a decent surgeon, because when you look at the Dutch TME trial and you look at CR07, these patients had incomplete surgical rates and they were lumped in together. Mercury had about 5%, but if you take all of those nodes out with your surgery, they are now gone, and you can save these patients having unnecessary radiotherapy, which is morbid. So again, the current guidelines in the UK and much across Europe and now going into the States as well is that patients do not need to have radiotherapy on the basis of a few suspected mesorectal nodes alone. When Phil Quirk went back and looked at the CR07 paper in greater detail, what he showed was that you could then look at the surgery and define it in terms of how well the surgery is being done. And if you've got good mesorectal surgery, and that's what we use as the Quirk grading now, radiotherapy is of minimal benefit, less than 3% benefit on the same CR07 paper. Everyone asks about nodes close to this resection margin. Well, actually, it happens very, very infrequently. And when it does happen, perhaps you don't need to give patients neoadjuvant treatment, again, on the basis of a node that's within a millimeter or sitting on the circumferential resection margin. Perhaps what you need to do is go and speak to your radiologist and say, where is this node, and can I perhaps tailor my surgery around that? So again, we don't routinely give patients radiotherapy on the basis of a node sitting on the CRM or near the CRM. Pelvic sidewall nodes, very briefly. Well, of course, we in the West use neoadjuvant chemoradiotherapy, and our Japanese colleagues think of doing pelvic lymphadenectomies. We need more data on this, and perhaps the use of fluorophores such as indocyanine green, like the gynecologists do, would be able to better target our surgery. The use of a robot, the use of more dexterous, minimally invasive platforms perhaps will help. And I know that there are several trials currently being undertaken looking at these with those different components I've mentioned. Restaging, very quickly, well, very contentious. If you're going to restage, apples and apples, oranges and oranges, there's no point doing an MRI first and the CT later. If you're going to restage, you restage with the same imaging modality using the same technique. The trigger trial, which we set up with Gina, is something which is currently being recruited for. We perhaps will get more evidence from this. But what are the arguments for or against it? Well, if you want to restage a patient, you can then decide on your surgical planning with far greater precision. Often these patients would have had their baseline MRI scan 3 to 6 months previously, and a lot could have changed. You can look at certain prognostic and predictive features, and then we've seen that from some of the recent literature. And of course, the possibility of complete response, which we now all have to be completely aware of. There's the timing of the scan, and there's the timing of the surgery. And in the 6 versus 12 trial, we've now seen that 12 weeks is the optimum time for doing surgery after you've had your neoadjuvant treatment. And in some cases, you may change strategy. A patient, let's say he's one of those 1 in 6 patients that has a complete response, may decide that, actually, you know what, I don't want to have an operation anymore. The flip side to that is, well, you can't offer them any further neoadjuvant treatment in most cases. Most commonly, you don't change a strategy, and often resources are poor. So trying to do an MRI scan, again, may not be in your interests. If you're going to report it using the same protocol, and you can look at the TRG based on the Mandard pathological scale of fibrosis, and we know patients that respond well and have favorable TRGs do better. Those that have minimal fibrosis do worse. And these are just, again, some pictures of what we see when we see radiological complete response, of course, different from pathological complete response and different from clinical complete response. And finally, a treatment algorithm that we use for low rectal cancer based on MRI scan. And this can often help determine whether you've got to have sphincter sparing surgery, whether you're going to have a local resection, whether you're going to have neoadjuvant treatment, or whether in fact you need a beyond TME approach, such as extra levator surgery, or even an exentration. Thank you very much.